All right, I think we'll get going. Good afternoon, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director of the Havey Institute for Global Health, and John P. Fair, Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern University Feinberg School of Medicine. Thank you very much for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health's First Friday Seminar Series. And today's seminar is entitled Digital Innovations for Global Health. Please take a moment to follow us on Facebook and Twitter at #FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Today, we're very excited to have Dr. Bethany Hedt present the seminar today. Dr. Hedt is a biostatistician specializing in health systems and implementation science research in sub-Saharan Africa. She's an associate professor of global health and social medicine at Harvard Medical School and in biostatistics at the Harvard Chan School of Public Health, and the director of research for the program in global surgery and social change. She leads a body of research related to cesarean access and care in rural areas of Rwanda and digital health interventions in sub-Saharan Africa. Dr. Hedt is committed to improving partnerships in global health research by innovating with her own practice and by leading research and advocacy on issues of power dynamics and inequitable research collaborations. There will be time for questions following the presentation, at which time we welcome you to submit through the Q&A feature. Matter of fact, you can submit at any time during the presentation. Please use the Q&A and not the chat feature at the bottom right-hand corner of your screen at any time throughout the presentation. And Dr. Alicia Hirschhorn and I will lead the question and answer period at the end of the presentation. And so now, Dr. Bethany, may I call you? I turn the program over to you. Thank you again for joining us today.
Great, thank you, and thanks for the invitation. I'm excited to be here, both to share some work, some of which is hot off the presses or not even in press yet. So looking forward to sharing that and getting feedback on that work, but also wanted to use this as an opportunity to share some current thoughts and musings about the role of digital innovations in global health. And so I hope this really is a conversation and want to hear other people's reflections on some of these thoughts that have been percolating for me for the last few years. So just as a baseline, because you'll hear me use the term global digital health quite a bit, I just want to start with a few definitions. Global health for me is the research and practice activities aimed at improving healthcare access and health outcomes in marginalized communities. For me, global health is really defined by health equity and trying to target marginalized communities. It's not a geographic focus, but you will find that most of my work is in sub-Saharan Africa, particularly in Rwanda, and so I'll be highlighting that work for you today. And then digital health is leveraging digital technologies to improve healthcare access and outcomes. I think oftentimes when we think about digital health, we immediately think about mHealth applications or maybe telemedicine and telehealth more recently. But it, for me, is a very broad set of tools that we can use. And thinking about it as a broad set of tools, things like EMRs and information systems, as well as these digital tools like mHealth apps, will help us think about ways that we can integrate systems and work across systems to really fully optimize the types of digital interventions we're trying to deploy. So combined and relatively obviously, when I talk about global digital health, I'm talking about the leveraging of these digital technologies to improve healthcare access and health outcomes in marginalized communities. The field of digital health for me has really been around since the start of my career in global health for the last 20 years, and really increased and emerged more over the last decade. And many people point to this field as, the next generation of healthcare delivery around the world, not just in the global health context. And you'll see terms used like panacea and leapfrogging. And really, this is going to solve a lot of the challenges and problems that we've been trying to address. And so a lot of hope in the use of digital innovations for addressing some of the global health challenges that we've grappled with over the last centuries. But similarly, or equally, there's concern about the role of digital innovation and how it's scaling and how it's growing. And here's just a few examples of publications that have come out and comments that have come out over the last few years talking about things like scalability. So a lot of use of pilots, but not getting things to scale. Things related to scalability, which is a lot of different pilot projects and things feeling very fragmented, but systems not working together. And then an important one to think about is how digital solutions might be optimizing outcomes for certain groups, but further marginalizing others. And so really trying to think about how we use these digital innovations to address challenges without further exacerbating issues within the existing health system. And a lot of the challenges that folks highlight goes back to this idea that we have a lot of pilot projects and innovations and great ideas that just live in this space, but never get into the scale that we need to really be transforming healthcare systems or be transforming the outcomes of patients who are seeking care through those systems. And so the question often remains, how do we take the best of digital innovation and really improve the health of the populations that we serve? A group a few years ago came out with this principles for digital development. And it really was trying to address or offer principles that we can think about as we're developing digital interventions that will really make these interventions be intended for scale and for population level implementation. And I won't go into detail of all of the different principles, but just as an example, one principle is designing with the user, another is being data-driven, collaborative, reuse and improve. All of these principles, for me, really in my day-to-day work, boil down to two tenets that I try to embody in my work. So the first is that global digital health has to be problem-driven work developed with and for partners. So if we want to really be addressing these health inequities, we need to start with a problem, not start with a digital tool. And I'm going to illustrate how we use this approach, this problem-driven work, and how we work closely with partners by illustrating two examples from my own work, one related to C-section care in rural Rwanda, and the second related to maternal health care in Zanzibar, Tanzania. The second tenet that really drives the work that we do is this idea that for global digital health to have maximal impact, we need to be convening multidisciplinary, multi-perspective teams to brainstorm how digital health tools can address these problems. So in the context of a particular problem and working closely with partners, we need to engage experts across a range of skills to fully and comprehensively develop a tool that's going to work in a particular context and have the potential for scalability. And these are just buckets of skills that I think about when I think about the types of teams that we engage, but individuals who have skills in analytics, individuals who have skills in actually developing the tools and devices and the systems that we use, and then individuals who have expertise in the evaluation, things like acceptability studies, implementation science, context assessments. And if we only draw a single skill set, or even from a single bucket of skill sets, we're really limiting our understanding of the problem and also our understanding and optimizing of digital tools to address those problems. So as I said, I'm going to try and illustrate both of those tenets with two examples from my work. I'm going to start with home-based post-C-section support in rural Rwanda. And if I talk about multidisciplinary teams and needing people with a range of expertise, I think it's most important to start with the team that we work with. So I'm really dependent on multiple individuals and inputs from different perspectives for this work to be successful. And I'm just here representing the work on behalf of that team. But as an example, my co-PIs over the last series of grants have been Vincent Chewbacca and Frederick Katera. They're both medical doctors from Rwanda. Fred Kater is the Chief Medical Officer for Partners in Health, which is our main partnering organization. And Vincent Shabaka is the Director of Research. I rely on the clinical expertise of Robert Riviello, who is a surgeon, general surgeon, and Adeline Boitin, who is an OB-GYN. And then for some of the AI work, machine learning work that I'll talk about, collaborate closely with Richard Fletcher, who is an mHealth specialist at MIT. We have colleagues Laban Bikaramana and Annie Ngina, who really help us lead these studies on the ground, and they make sure that our work is embedded into clinical practice, but also that clinical practice is constantly informing our work. And then a series of students and postdocs that are working with us currently, and you'll see some of their work highlighted as I go through. What are we working towards? Well, at this point, we're working towards home-based care for women after cesarean delivery in rural Rwanda that is led by community health workers. And as a bit of background, C-section rates have been increasing globally for the last 20 years, and those increases have been linked to lower morbidity and mortality. However, the increased number of C-sections has also led to an increased number of C-section related complications. The most common and the focus of a lot of our work is surgical site infections, which an estimated 8 to 48% of women who deliver via C-section in sub-Saharan Africa go on to develop a surgical site infection as a complication of that C-section. Specifically in Rwanda, 15% of women deliver via C-section, although the rate of C-section delivery is lower in some of our more rural areas. And there is a system of community health workers in Rwanda that are already in place and support women during the prenatal period and support women during the postpartum period, but they're not currently capacitated to support women specifically for C-section follow-up. So a woman who delivers via C-section may get a home visit for an assessment for her child and maybe some general postpartum assessments, but she's still expected to travel back to a health center for the C-section specific follow-up related to her surgery. It's a really exciting time to be pursuing this work in Rwanda. There's been 2 recent developments that further facilitate the work and also really get us excited about the potential of scalability of the interventions that we're looking at. The first is about 4 years ago, Mara phones launched in Rwanda, and this is the first Africa-made smartphone. It's available for $100 to $200 per unit, has full functionality of any smartphone that you would buy off the shelf anywhere in the world, and it really increases the accessibility of phones to various populations that we support. The second is that starting this year, Rwanda started to realize its vision of getting a smartphone in the hands of all 40,000 community health workers in the country. And so now we can think about these community health workers have phones that can be used to facilitate their clinical work. And what do we put on those phones to really optimize those exchanges with community members? A lot of the specific work that I'll talk about comes from research that we've been doing in Kirehe District. Kirehe District Hospital is a hospital run by the Rwanda Ministry of Health with support of the international NGO Partners in Health. It's here located in southeast Rwanda, very close to the Tanzania border. And from a series of early research projects, we learned things about care access and care outcomes for women delivering via C-section that really got us thinking that we need to be pursuing home-based follow-up. So this is just a summary of some of the key points that have pointed us in this direction. So one is that a high percent of women do go on to develop surgical site infections after cesarean delivery. We found that the long distances between a woman's home and her health center and the hospital are linked to poor maternal and neonatal outcomes related to the cesarean delivery. In a qualitative study, we found women reported that the C-section follow-up, the requirement to go from their home to the health center for follow-up, was physically and financially burdensome. And then in a financial study, we found that 23% of women experience financial catastrophe just from the procedure, from the time of the cesarean delivery up to hospital discharge. But that tripled when we accounted for the costs related to the health center follow-up after hospital discharge. So how do we facilitate this home-based follow-up by community health workers? We've pursued a couple of different approaches, so I'll talk through those and then lead you to where we're at right now. Our first attempt was just trying to identify a simple screening tool that was predictive of surgical site infections, and then using that simple screening tool, question-based screening tool, to identify surgical site infections, either by a community health worker visiting the home and running through the questions using the mobile device to prompt her for certain questions, or the community health worker calling the mother and asking those questions over the phone. And then we have a third arm of standard of care where we compared the follow-up rates between the three arms to see whether or not this deployment of a simple screening tool for surgical site infections had impact on follow-up and return to care. So the good news is we found that the home-based follow-up by community health workers was feasible. Around 88% of those who were randomized to that arm were found, were agreeable to being followed by community health workers, completed the screening. Some of our challenges, though, this study really pointed us to the fact that the phone call follow-up right now in Rwanda is not feasible. And this is an important finding for us because a lot of what is being prompted for post-cesarean or post-surgery follow-up in East Africa is to call patients or to text patients after they are discharged from the hospital. And while that may work in some settings, for us, 32% of women would be missed by that type of intervention. And it's not a uniform missing. It's women who are the most rural and the most poor, so already marginalized, are more likely to be missed by a phone call follow-up than their counterparts. And then we did identify a screening tool that was predictive. So if a woman reported having a fever, having discolored discharge from her surgical wound, having pain, that had good accuracy in the clinical setting, but that accuracy degraded when the community health worker asked those questions in the home. And we have some theories for why we think that happened, but essentially have at this point abandoned a simple question-based screening tool as what we think will be a safe way of identifying surgical site infections in the woman's home. So then that leads us to our second attempt. We were really enthusiastic by the fact that community health workers could go to the woman's home and support follow-up. And so we tried to optimize on that and to use telehealth, where the community health worker would take a photo of the surgical wound, text that photo to a general practitioner, and the general practitioner would review the image and text back whether or not the general practitioner believed the woman had a surgical site infection or not. To facilitate this, our team also developed this wound screener app, which you can see pictured here. And this is effectively like the check readers or the credit card readers that you have on your phone. That is a way of both standardizing what is captured in the image and sent to the general practitioner, but also we're integrating now in some data quality checks to make sure that the image is of good quality, good brightness, good contrast, and whatnot. So from this study, again, we continue to show that this is feasible. 90% of the women who we followed using this telehealth intervention received a diagnosis. Almost 80% of those, over 80% overall, received that diagnosis within 1 hour, which was our target in terms of the length of visit for the community health worker. We've also done qualitative work to show that women and community health workers found this type of intervention highly accessible. And part of our, acceptable, and part of our qualitative work extended into the start of the COVID pandemic. And so the acceptability and interest in this type of intervention increased, as I think we would expect during the pandemic, where women were concerned about their risk of exposure to COVID if they had gone back to the health center for follow-up. However, the accuracy still remained low. We got better accuracy. It was close to 80% sensitivity and 70% specificity. But one of the concerning factors that we found in our review of this approach was that there was not good agreement between reviewers. So I could look at the image and Dr. Murphy could look at the image and we could give different diagnoses. So even if our overall accuracy was high, the inconsistency in reviewer diagnosis led to concerns about how much people would trust this type of tool moving forward. So now what? Again, we're really enthusiastic about this. We think this is super important. We think this addresses a lot of needs within the community, but we can't move forward without a better surgical site infection diagnostic tool. And one of the requests that we got from the Ministry of Health representatives on our team was the app needed to be more comprehensive. So we focused largely up to this point on surgical site infections, but their point was, if we have a community health worker doing a post-cesarean assessment in a woman's home, she needs to be able to assess more parts of the woman's recovery than just whether or not her wound is infected. And so this is the focus of our current work. In terms of the better diagnostic tool, we're now starting to explore image-based algorithms developed using machine learning to try and predict whether or not a woman is likely to have a surgical site infection. We were able to use images and diagnoses that we had collected over a series of studies to start that initial training. And two results that have recently come out, one is using photographs. So it's literally just taking a photo of the wound on your phone and using that photograph to predict surgical site infection, and using transfer learning convolutional neural nets, get sensitivity of 80%, specificity of 70%. And so decent sensitivity and specificity, and we're actually implementing some additional adjustments, like using the color calibrations from our wound screener app to try and improve those accuracies. Really exciting for us is we, just as plausible, but there wasn't really a lot of literature out there, collected thermal images as part of our most recent study. And we're actually able to get much better sensitivity and much better specificity using these thermal images than we were with the photographs. So for the thermal images, it's just an add-on to the mobile device. My husband, who works in environmental engineering, he has one and goes around and checks the seams of our house to see if we have any leaky windows or any drafts coming into our house. So you can buy them off the shelf, add them onto the phone, and capture a thermal view of the wound rather than just a photograph. And here we get really good sensitivity and specificity. We also think that this algorithm is going to be more robust to diverse populations. So we might be able to take an algorithm developed in Rwanda and use it in Uganda or Ghana or Mexico, where the photographs might be more sensitive to specific skin tones. Another study that we're doing as part of this image diagnostics is trying to understand the quality of images and how that affects accuracy. So these are, they just presented them this morning, so literally hot off the press results from two students, Monique Abampaye and Siona Prasad, where they look at the brightness as an example. And if we decrease the brightness of the image, where does it start to break down in terms of the sensitivity and specificity of the overall classification algorithm? And so you can see here, there is some room for decreased brightness, but at certain levels, the sensitivity does start to tank. And this is going to be really important for us, one, for thinking about what environments can we capture these images for surgical site infection diagnosis. Can it be done in a woman's home? Does it need to be in a bright lit setting? Do we need to do auxiliary lighting to be able to get these algorithms to work? But it's also important for our image quality checks that we're trying to build into the phone, where the system could automatically say, that image isn't bright enough, please retake the photo, so that we can make sure we're getting good accuracy in the diagnoses coming out of the algorithms. So we want to integrate this into that more comprehensive app. And so we're engaging a team of engineers at Inside of AI in Rwanda, who are taking the machine learning surgical site infection diagnosis algorithm, but then putting a comprehensive assessment app around it. And what's going into that comprehensive app was developed by a team of Rwandan clinical and programmatic leaders, coupled with individuals from the region and global experts, just trying to think about, could what we're recommending for Rwanda be generalized more broadly. But this team recommended a series of other assessments that should be done at these home visits. And then we've developed Rwanda-specific graphics to couple those assessments. So for example, when the community health worker prompts to ask whether or not the woman has difficulty breathing or shortness of breath, there'll be image icons that are built into the app to facilitate that prompt. So in summary, we're very confident that home-based follow-up is feasible and would address financial and physical challenges that the women face. And the image-based algorithms look promising. But we're in a series of work, both trying to further refine these algorithms, think about generalizability, where will they work outside of Rwanda? Can we predict infection using images captured earlier so that we can triage a woman into care earlier and have more success in her treatment for surgical site infections? And then we have a series of studies that will start later this year that will evaluate this app to see if it's usable, does it yield valid results when used in the community, and then does it have impact on time to diagnosis for C-section complications? I'm going to quickly introduce you to a second example, just again to illustrate how we bring these problem-driven digital technologies to life. Just give me 1 second. And I'm going to illustrate that example with some work with D-Tree International in the Zanzibar Ministry of Health. So this slide has fewer people represented because 99.9% of the work, the really hard work, is already being done by the Zanzibar Ministry of Health and D-Tree International, where they've already scaled the digital intervention, the core digital intervention, to the entire community health worker system in Zanzibar. And I'll talk a little bit more about what that system is. But I do want to highlight biostatistician and data scientist Izzy Fulcher, who I work with on this work quite a bit, and then 2 students who are currently supporting some of the research that I'll show here. The Jamii Afya program engages all community health workers in Zanzibar, and they visit women in their homes. The initial program supported women from the prenatal period to 10 days postpartum, but I think 2 years ago, the program expanded to follow the children through the first 1,000 days of life. So really integral parts of the important times in a mother and child's life. And one of the, what I would put into the space of digital interventions is, as a byproduct of the fact that these women are supported by community health workers who are empowered with mobile devices to support the visits, we were able to use that data and just monitor the implementation of the program and see, is it achieving targets? Are there gaps? Are there places to improve? So this is some of that early work where we were able to identify, who is getting covered by these women, how many visits, and then the facility delivery rates within the women who were being supported by the community health workers. So the target for the facility delivery rate was changing over time, so 60% in the first year, up to 80% in the last year of the period covered in this work. And you can see that the intervention is achieving improved facility delivery rates, but that they are falling short of their 80% target of facility delivery rates for women enrolled in year 4. And one of the questions that we've been asking with D-Tree is, facility delivery rates are now higher, but can we identify those 25% who are failing to deliver in the facility and do targeted interventions to improve their likelihood of seeking the facility when they're in labor? So the first step of that work was just trying to see whether or not we could get good prediction algorithms. And so this is looking at a series of different prediction model building approaches, and then also looking at a series of ways that we could deal with the imbalance between those who delivered in the facility and those who delivered at home. So we had much more representation of facility delivery, and we didn't want to overpredict facility delivery. So these are balancing techniques that we use. And what we found is across a series of approaches and across a series of balancing techniques, we were able to get decent sensitivity and specificity and worth continuing to pursue the algorithm. As we looked at this further, we did find that the gray bar is the percentage of women who fall into a particular classification score. So the first 10% in a classification score, the next 10%, and so on, so in deciles, and did find that the proportion of people captured in that score that delivered at home were likely to increase along with the score that they received. So it is truly accurately predicting the risk of facility delivery. So at this point, what we're interested in is if we identify these women who are high risk of home-based delivery, is there something that we can do to target these women to facilitate and increase their likelihood of facility delivery? And we're trying to evaluate this in a randomized trial where we will take women and, according to their risk classification, randomize them either to a birth planning intervention that gets additional supports and counseling and prompts for saving money and things that the team at D-Tree have already demonstrated to be useful and successful for facility delivery, versus standard of care. And we would use a weighted randomization scheme where those at higher risk for home-based delivery would be more likely to get the intervention, and those at lower risk of facility-based delivery would be less likely to get the intervention. But the value of this weighted randomization is that actually at the end would allow us to do a cost-effectiveness analysis to say what is the cutoff that optimizes facility-based delivery but has the lowest cost implications for the program. And so by randomizing across the risk scores, we can explore different cutoffs and different intervention levels to try and understand that cost-benefit analysis, cost-benefit relationship. Another thing that we've been looking at is whether or not we can trick the algorithms to give a different outcome. So if we do end up deploying these algorithms to target interventions, and if there is a desirability for those algorithms, is there a way that the woman or the community health worker can change what they put into the system to try and get a desired result? So for example, if the community health worker is giving extra money for transport to women identified as high risk for home delivery, will she want to try and get that outcome for women in her community by giving a certain value? And so we're doing some work to try and understand how vulnerable these algorithms are to manipulated values. So this is an example. Access to electricity has big influence in our prediction algorithms. And if a woman changes her value, or the community health worker changes her value from having electricity to not, then that will 5% of the women will then get the intervention who wouldn't have normally been classified for that. This will give us ideas of what we need to monitor as we implement these algorithms, just to make sure that folks are implementing them with the intentions of the algorithm and the interventions that are being deployed. So that was a very fast introduction and a short snippet of what we're doing with the D-Tree collaboration. But what we're finding is that implementation science assessments relying on data collected as part of these mHealth systems are incredibly important for program tailoring and really understanding how the programs are working and where they need to improve. And that prediction algorithm work can identify high-risk individuals for failing to deliver in the facility. In our future work, we'll try to further evaluate the use of these targeted algorithms, and can they really be deployed in real time? Do targeted interventions based on those classifications really have an impact on behaviors, is what we're planning on doing in the next year. So with those two examples, I just want to end with a few thoughts of where do we go from here, and how do we get from really interesting and creative innovations to the true impact that we hope to achieve. And I summarized here recommendations across a series of papers that talk about some of the challenges of digital health and mobile health in global context, and what they recommend for these programs really having optimal impact. I'm not going to go through all of these. There was a lot of agreement across the sets of recommendations, but A few that I want to highlight is, again, emphasizing the importance of context, talking about making things open, of which, I would love feedback on this. Generally, I like the idea of sharing and reusing tools, data, resources that we've developed. I also have concern about just openly sharing data may not allow the benefit for the people who've generated the data. So I think that's worth discussing when we talk about equity and fairness in the research practice. But several sets of recommendations for how to start scaling this innovation and having impact. When I think about it within my own work, though, and again, kind of distilling it down to my role as an academic researcher working in the space, trying to facilitate innovation in global health, what I'd like to end as a recommendation for the Academy, if we believe that global digital health is problem-driven work developed with partners, and if we believe that this work requires multidisciplinary, multi-perspective teams to really best solve these problems, then we need to facilitate collaborative partner-driven research. And this is not just true of global digital health. I see a few familiar names here, and we've probably had these conversations before. But really, one of the biggest challenges that I face in having my work be partner-driven, and one of my biggest challenges that I have in trying to work with folks with various expertise, is that is not always supported and promoted within the Academy. And we really need to start breaking down some of those barriers to do this work well. So just on that spirit, I want to end with a couple of writings that our team have done on this topic. The first is just highlighting how we've tried to be partnered, focused, and collaborative in our global surgery work, under which the work I just presented on C-sections falls. And the other is some thinking more broadly about how we change promotion policies to address equity and collaborations, how we partner, but also how we really work together even within our own teams at our institutions to solve these problems. So my goal, hopefully I achieved this goal, was to demonstrate a range of problems that we have addressed using global digital health and how we've used innovation within our own work to solve specific problems. And then I hope I planted some seeds that will facilitate a broader conversation on how we realize the promise of digital innovation in global health. There is a ton of opportunity. This is a panacea. It can leapfrog. It can do all those things. But we really need to think about some of our issues within the Academy, or some of the issues with digital partnerships and how things grow and scale to make sure that they truly are achieving impact. So some acknowledgements, and I'm sure I'm failing to acknowledge all who have touched this work, but grateful for everyone's contributions and look forward to questions, feedback, other thoughts for me to carry on as we conduct this work. Thank you.
Great.
Thank you very much, Bethany. Lisa, you want to take over the questions?
Absolutely. So thank you so much, Bethany, and really exciting to hear. I've sort of heard snippets of this sort of in the past. So we have one question right now in our Q&A. I would just really encourage other people to put some in there. I have a number of them, but I'm going to first go. So thank you, Judith Maisel, who says, how are global partnerships determined and then coordinated? And what an honor this must be. Many thanks to all.
Great question. And, Lisa and Rob, I would love you to contribute as well, because I'm sure you have perspective on this. For me, it's largely proximity and really, and actually, if I think back to this, the Rwanda work, which is where I spend most of my energy and most of my time, was really initiated by Lisa, who was in deep partnership there with colleagues at Partners in Health Rwanda, and said, we have this problem that we think you might have insight on, will you come? And then that turned into a 12-year relationship, for which I lived in Rwanda, and really just tried to not just use that as a chance to understand what was happening within health systems, but really just to develop the friendships and trust that you need for someone to say, hey, we have this idea, can you help us pursue it? Or to say, your idea is a terrible idea. And so for me, the first part of how do you develop partnerships, or how do you know when there is truly a partnership, is proximity, and just those trust and relationships is foundational to that. I don't know if I can take speakers' privileges and invite Lisa or Robert, if you want to comment on that as well.
Well, I mean, I think you hit the nail on the head. I mean, it's really trust and taking those first couple steps, like you did with Lisa originally, and how it just blossomed from there. I mean, I think it's a great example of, you know, how these things can really end up having a major impact.
Yeah, I mean, I think it's probably one of the areas that global health has progressed in the last 10 or 20 years, where it used to be people would sort of drop in, do what they think was a good thing, take the data, which is sort of the modern day equivalent of extracting raw resources and publish. And and so it does take time. I think trust is the key thing. That was also the first thing I was going to say as well. And really want to sort of shout out to Bethany and the work that she and colleagues have done about the need both for you know, equity in global health, and say Mamola has been writing a lot about that, but also how that reflects on people like, you know, who are emerging people in the academy and academia, and how do we actually give people credit for the time that it takes to develop these relationships and really invest in the partnerships. One of the other things which I really struck me very much, and would love to hear a little bit more, is, you know, I've sometimes heard digital health being criticized as a solution looking for a problem. And the idea that you have really come into this idea about sort of what is the problem, and whether you would give some advice for people who are not working in cesarean section. Although I have to say, I don't know if I ever shared this with you, my first paper as a fellow was on cesarean section infections in Boston. So it truly is a global problem many years ago. But what would you suggest for people who want to say, well, how do I figure out what the next problem is that we should be working on?
So in my dream world, we would find ways to take the folks who are the geniuses in the engineering and the analytics. And, you know, if you think about this in drug discovery, right, there are people behind the scenes putting random chemicals together just to see what works, right? And I think there is space for that. But we have to find a way to take those geniuses and combine them with the geniuses who work in the field and have a sense of problems, and can think about this is the need that has the potential for a digital solution, but I don't know what the best digital solution is, and finding ways that those groups can really talk to each other. You know, the folks who are developing these tools, they want it to have impact, but they just may not have the relationships to really understand where it can have most impact. And so in my dream world, is I'm working towards collaborations where those teams can talk to each other and really understand, you know, this tool that you developed for cesarean, can I take the computer vision component of it and use it for tuberculosis diagnosis? Mm-hmm. And, you know, how do you cross fertilize, not just in a topic area, and not just even in a population, but cross fertilize across multiple topic areas and multiple populations? You know, even if you weren't talking about this for global health, I don't think those types of collaborations or conversations are facilitated in academic settings. You know, it's like, I need to be the person who's known for the thing. And so it's, you know, you just work in isolation and might be a little bit proprietary about what you share. And I think that can change, and would love to be part of a group that tries to take it to that really collaborative idea sharing environment.
Great. Other questions for Bethany? Otherwise, I have a whole bunch, but I want to make sure that people have a chance to put anything into the Q&A if they'd like.
Let me, if I just have one question first.
Yes, please.
So have you heard of Nest Newborn Essential Solutions and Technologies?
I'm not.
I'd like to add that to your partnership list. This is out of Rice University, and we're part of that. And it's finding technical solutions, including digital solutions, to neonatal health, focus on specifically neonatal. But I mean, I think there would be a really nice collaboration there, and they are in Tanzania, Kenya, Nigeria, and Malawi. But I'll follow up with you afterwards. It's a really great program.
I look forward. Go ahead.
I was gonna say, I see Kara's on here, and I just chatted her to see if I could actually get her to maybe, if I can unmute you if need be. Because Kara has a really interesting role with that, which is how do we think about scale and commercialization as well as development? And so, thinking beyond, if you get this to work, how do you get it then to work in other settings, potentially with less skilled community health workers? So,
there you go.
talk about it. Thanks.
Thank you so much for an excellent presentation. Yeah, NEST is really focused on newborn wards. So they can be, quite busy, maybe 40, 50 babies in a ward for one or two doctors. Or not, the ratios are just not one-on-one, like a community healthcare worker might be with one family. So just thinking about clinical decision support tools or EMRs, and sort of what you've seen work well in those very busy settings where the HR staffing ratios are just really difficult. Would love to get your thoughts on that, because we are trying to figure out ways to make life easier for the healthcare worker versus maybe harder.
Sorry, I muted myself. Yeah, no, would love to just sit down. I mean, it's probably for every specific idea, its own conversation. One thing that comes to mind though, as you talk about that is, we're largely maternal health, and I work closely with my colleague Adeline Boatin, who's the OB-GYN. She does a lot of maternal health, digital health in Uganda, thinking about how your newborn systems talk to our maternal health systems, and because it's not just about the mother, it's about the mother-child dyad, and really getting those systems to work together. But I know that there's huge potential in the clinical space to really think about triaging either human resources or testing resources by using better data-driven approaches. And so I don't know if there's any specific ones you want to give details on to talk about, but would definitely love to hear more offline if not.
Great, thanks. We have another question from Bernard, who is one of our postdoc fellows who's here visiting from Tanzania and is actually deeply involved in obstetric care. And his question was, how often, proportions, the digital applications have been applied into routine care by ministries of health, and how seriously the IP has been taken for the benefits of the creators of applications in Africa?
It's a great question. I don't have specific numbers in mind, but Bernard, I definitely, the challenges you're highlighting, I hear them, I understand them. I can't say how often. I mean, I would say less often than not. Digital interventions have actually made their way into standard of care, but there's certainly ones that we can point to, right? Like care systems have been implemented in by a lot of ministries to support various care activities of community health workers. The D-Tree example I gave you, and again, I take no credit for this part of the work, is being implemented at scale for the entire island of Zanzibar. So there are examples of these different tools being integrated into various components of Ministry of Health work. Your second question about IP is one that I think is really important, and again, would love other people to weigh in on this. It is hard because institutions in the US and probably other places are really set up to think about IP. Individual researchers may not. So I am a dunce when it comes to IP. I've been told that I should probably think about filing for IP. And the conversations for me really break down to exactly what when we start thinking about the questions that you're asking, which is, I'm not trying to make any money off of the surgical site infection prediction algorithms. My hope is that if there is any money generated from that, which I can name numerous scenarios where there might be, that it either goes back into the research, or it goes back into the health programs, or it goes directly to the women who maybe not the women who are contributing data to the algorithm, but are in the communities where that data was generated. But those are, and again, I'm happy for others to chime in. I don't see examples of that laid out that can be the roadmap that I can put forward to my institution for us to pursue with IP. Bernard, I don't know if you want to add. I can't actually see the comments. I don't know if you want to add to that in your comments, but it's definitely one that I'm highly concerned about. We on a long shot, just to show you how we realize this in our work, we on a long shot submitted for a prize. We don't know if we got it or not, but it was a monetary prize. And even before we submitted, we sat down with that core team on the slide, the first slide for our C-section work, and said, if we were to get this prize, how would we divide up the money? And it was like a third directly to the communities, a third to patient care, and then a third to the research divided amongst the research collaborators. So we definitely are thinking about it, but in terms of IP, we have not figured it out.
Great. Thank you. Other questions? If not, one question that I had is, there's this idea about creating demand and creating sort of supply. And by that, it's sort of identifying the women with possible or actual cesarean sections. And the discrepancy is an interesting one, because we found that often some obstetricians would say, no, it's not a surgical site infection, but we'll give some antibiotics just in case. So there may be ways of doing that. So I guess I have two questions. One of which is, of the people that you missed, how many of them had sort of minor infections that probably would have gotten better maybe on their own or with a little bit, versus sort of the serious deep-seated infections? And the second is, and I realize that Kirehe is a little bit different, but what's the sort of flip side of saying, what's the readiness of the hospital to actually accept the fact that these women are being sent in by a community health worker, and then to appropriately manage them?
So a great question. The first one, we don't have the data readily to answer that, and it has been a big gap in our research today. And so we have 2 new prospective studies that will start this year, and we'll be better able to answer, Lisa, are we just missing superficial, or are we missing ones that are really consequential? It is a mistake of ours to not have collected that up to this point, but one of the comments we do make with that is, even relatively super surgical site infections can progress if they're not identified early and treated properly. So, our goal, even if it's superficial, is to get those women into care and get them resolved. So your question about the readiness of the hospital, in a lot of ways, hopefully this is, addressing some of the challenges they have, not introducing So, right now, women who deliver via C-section are expected to go back, all women. And so that's a huge responsibility to provide the clinical follow-up for all these women. And so the hope is that we can really triage. And so it's the ones that are identified as high risk. So it reduces the workload of the health centers and the hospitals. All of our assessments include both clinician input in the development of the tools, but also our acceptability studies always get clinician input just to make sure that we're addressing any concerns that they have, but generally very well accepted across different populations.
Great, thank you. And I'm gonna, I think Rob's gonna answer one question, but just one suggestion for you is, one of the domains of quality that is often ignored is timeliness. Mm-hmm. And I think if you can capture not just the ability of it, but also the time that it takes to actually diagnose and then get a woman there, I think in the concept of the delays, because you're sort of addressing that to some extent, the first delay, but also then the second delay may also help strengthen the impact of your data as well as your thing. So Rob, I think you were going to answer one of the questions.
No, I think Bernard, I would try to do it in the Q&A, but it failed. It was I think, asking about the NEST program and how to contact them. And it's just Newborn Essential Solutions and Technologies out of Rice University, their biomedical engineering department. You can just Google that and you'll get to their program.
Yeah, it's nest360.org.
Nest 360, right.
here.
You can also, I'm Kara, this is me on,
Yep.
you can email me. I put my
Yep.
email in the chat and I can direct you to the right folks. Thanks.
Great. Any other questions? I think we have answered all of them in here from the audience. Would love to know, I think some of our surgical colleagues are not around and would love to sort of hear their thoughts about using this. I know there's some similar work that Jaime Miranda's doing around diabetic foot ulcers, I think in Peru. And so really interested in how do you sort of collaborate so everybody isn't doing their own independent R01 with new sort of addressing these issues, and particularly interested in the thermography, because I know that as Rob can attest, that some of the issues around skin color certainly have been a challenge when using visualizations.
Yeah, I was very impressed with that. Thank you.
Yeah. Any thoughts on that, Bethany? Is that happening? Is that something that the Institute could help in terms of making linkages?
So it definitely is probably an exposure issue, but I don't know of other groups that are currently using heat profiles to do surgical related work. And it looks incredibly promising. So we're very excited about it. You know, one of the challenges of it is it's not built in. So you need add-on devices to do it. And they're like $200 now. Our colleague, Rich Fletcher, that we work with on this work, he is very confident that those camera prices are going to come down because they're relatively new in the market. But he's also confident that if we can show enough benefit of thermal cameras, so if we can show a health benefit and the ways we can use it in various apps, and then my husband Nathan can show benefits for like green building and, you know, winterizing your home. Like if you can show these benefits, then eventually there's going to be the iPhone 30 that's going to have a thermal camera just built into it, right? There's totally the capacity to do it. You just have to do it. So I think that's for us a really exciting area. We're applying for a grant now to see how transferable are the visible image algorithms versus the thermal algorithms. And we're more hopeful for the thermal, and it would be huge, right?
Yeah.
So
great.
Well, maybe we could just wrap it up now. Thank you very much, Bethany and Lisa, for leading the discussion, and Kara for chiming in. Very important comments. We really appreciate you here. I want to thank you, Bethany, for taking the time to share your insight and expertise with us today, and thank the audience for joining us and submitting your questions. And we invite you to join us for the next installment of the Institute seminar series, which will continue on Friday, September 2nd. There's no seminar program for the month of August because too many people are gone. So anyway, again, thank you very much for joining us today. And for those that have registered, a recording of the webinar will be shared via email. And this technically concludes today's webinar. Thank you again. Thank you all.
thank you, everyone. Take care.